Good morning. Well, when Simon Lowe gave me this topic, diagnosis and management of afferent limb obstruction, I thought, that's so rare. Why would the audience be interested in something that they're probably never going to see? But then on further thought, actually, what we've learned over and over in medicine is our ability to help our patients with treatment depends on our ability and our awareness to make a diagnosis. And afferent limb syndrome is probably something that's often overlooked. So it's probably more common than we think. It's estimated to be about 1% of cases, but if you look at the literature, about a quarter of the patients who've had a prior Whipple will develop afferent limb syndrome. So I think awareness about afferent limb syndrome is very important. So I agreed to give this talk this morning. So what's an afferent loop? What's also called the biliopancreatic limb. So the surgeon divides the small bowel and reconstructs the small bowel with two limbs, with two separate passageways. The one passageway is the efferent limb, and that's to pass food. And the other limb is for bile and pancreatic juice passage. That's the afferent limb. So here you can see the arrows showing the afferent limb. Now, from our perspective as endoscopists, we differentiate between patients who have their native papilla intact and those who have an anastomosis. So these are the two categories that I look at. We have patients that have had a B2 or post-gastrectomy, gastric bypass, duodenal switch. So here, the native papilla is still completely intact. The challenge is getting to the papilla. And then we have the patients who have an anastomosis. And it may just be a hepatojejunostomy, so a biliary diversion procedure, or it may also add a pancreaticojejunostomy. So that's the Whipple operation. So you can see here the images where an anastomosis is present. So the afferent limb syndrome is where bile acid, pancreatic juice accumulate, as well as intestinal secretion. You know, the intestine secretes a lot of fluid. And over time, then, the intraluminal pressure increases. And this results in dilatation of the afferent limb. So you can see the obstruction here, and the afferent limb here, normal here, starts to dilate up. Now, the causes of obstruction can be benign, but we rarely see that. Every once in a while, you'll see a case report for a Bezoar or enterolith or so causing afferent limb syndrome. Adhesions can certainly cause that, but we most commonly see patients who have a history of prior malignancy, especially pancreatic cancer, who have undergone Whipple operations. So recurrence of malignancy is the most common cause. And in one study, 33% of patients presenting with afferent limb syndrome post Whipple had malignancy. But interestingly, more patients actually had a benign entity that was due to the radiation. 38% of patients presenting with afferent limb syndrome post-Whipple did not have malignancy. It was just due to radiation. So it's important to ask about a history of prior radiation. What are the risk factors for developing ALS in cancer patients? Longer survival, a longer afferent loop, greater than 30 centimeters, history of prior radiation, as we discussed, and patients who have had anticolic surgery, which can result in more kinking, volvulus, and adhesions. So that's why it's important to review the operative report. The clinical presentation is usually from the loop distension that causes pain, nausea, even bilious vomiting when that pressure builds up so high that you get overflow and the patient vomits bile. It can be due to impaired intestinal secretion, which can result in malabsorption, SIBO, vitamin B12 deficiency. Again, it's about the awareness to think about this as a potential cause for these things that those of us with internal medicine backgrounds should be thinking about. And then if the pressure backs up into the bile in the pancreatic ducts, well, then we have impaired biliary and pancreatic secretion. And that in turn can result in jaundice, cholangitis, even pancreatitis. So the diagnosis can nearly always be made on CT scan. We will typically see afferent limb distension. You see that here in the coronal or in the transverse views here. Call that the C-loop sign. We may see prominent valvulae, the keyboard sign. We may see a thickened bile wall, and we may also see bile or pancreatic duct dilatation in patients who are post-Whipple. So when we see that dilatation, that's when we really should have the alarm sign going off that this requires more urgent treatment. And then you can get a HIDA scan for diagnosis. Let's move to treatment now. So it falls into these three categories: surgery, percutaneous drainage, and endoscopic. Now, surgery, if it's benign, adhesiolysis, or creating a new anastomosis. And if it's malignancy, well, if it's really just local, truly local excision, but more commonly, the surgeon creates a bypass. It's a Brown's enterostomy. Well, that's what we're mimicking or able to mimic today with a Lamb's bypass. Percutaneous, the radiologist can place the stent directly percutaneously into the afferent limb and can also drain the bile duct. Endoscopic can be enteroscopy guided, may just be dilatation plus minus a stent, a SEMS. But more recently, we're hearing about EUS-guided enteral bypass. And that's where all the excitement is. So we know that enteroscopy guided approaches can be very challenging. We've heard a lot about this. The limbs can be very long and there's a lot of looping. Patient had a prior gastric bypass. We're talking about 2 meters. Sharp angulation at the entry to the afferent limb. And then if you have an obstructing mass and if the stricture is long, that makes it even more difficult. And if all of that weren't enough, now we have the challenges of using an enteroscope that are not designed for biliopancreatic interventions. There's no elevator, small working channel, and we need enteroscopy length accessories. So the bottom line is enteroscopy guided approaches are time consuming, high failure rates, and there is always a perforation risk. And so that makes taking the shortcut very attractive, EUS-guided enteral bypass. The Lamb's gastrojejunostomy post-Whipple for pancreatic CA is what we are seeing an increasing number of reports on. And I'm going to share one recent patient of mine, a 77-year-old male post-Whipple from pancreatic cancer. So here you can see the C-loop sign, the dilated afferent limb. He was admitted septic with jaundice, high white cell count, bilirubin elevated. CT also showed multiple abscesses in the liver. The afferent loop is dilated to 4.2 centimeters, and the PET scan showed avid uptake in the right upper quadrant. Here you can see the obstruction at the inlet to the afferent limb. On EUS, we see the markedly dilated afferent limb across from the stomach. And we then proceeded to place a 15-millimeter Lamb's. Here you see the distal flange in the afferent limb, the proximal flange, an immediate gush of bile. And then we can dilate the Lamb's and we can enter into the afferent limb and perform additional biliopancreatic interventions if indicated. And this is just the video that shows the same. So here we're entering through the pylorus into the jejunum, and you can see the obstruction. Now we've switched to the EUS view. We're placing a 15-millimeter Lamb's, the distal flange deployment, all of this under constant ultrasound guidance. We never take our eye off of the ultrasound image here. We completely disregard the endoscopic view, snug that distal flange nicely up against the wall, release the proximal flange from the working channel, and there we see the bile flowing. And then we can use that LAMS as a port to enter into the afferent limb. So here you can see before the C loop sign and after the LAMS placement. You can see it right here, and the afferent limb is decompressed. And here on our pneumogram, you can see air in the stomach and our LAMS connecting with the afferent limb. Now, obstructive jaundice as a presenting sign of ALS was first reported in 1979. Its first case report of a patient presenting with jaundice 25 years after a B2 gastrojejunostomy for peptic ulcer disease. Upper GI series, there was no filling of the afferent limb. There's no CT at that time. That's how they made the diagnosis. And the patient went to exploratory lap, showed marked dilation of the afferent loop, the gallbladder, and the bile ducts on exploratory lap, and a Brown's anastomosis was performed. Patient recovered. So an alternative to afferent loop bypass would be to actually go directly into the bile duct. So we're going to the highest level of the obstruction now, which is actually now the intrahepatic bile ducts. So if those ducts are dilated, we can just place a stent directly from the dilated left hepatic system into the stomach. And sometimes we do want to additionally dilate the afferent limb. Now, usually it's prominently, it's very prominent and filled with fluid and distended. So it's sort of the ideal patient for a gastrojejunostomy. But if you don't have that dilation, so for example, sometimes the patient may have vomited and the afferent loop is decompressed. Well, that's when you have to go in with a oroenteric catheter. You need to pass that into the afferent limb and fill the lumen with water. That's such a critical step for a standard gastrojejunostomy, as you heard about yesterday from Nguyen. So here you see the oroenteric catheter inserted into the afferent loop for water filling. So we're advancing the oroenteric catheter while we withdraw the enteroscope. And once the enteroscope is completely removed, then we're going to go alongside that catheter oroenteric with our echoendoscope, and then we can inject contrast through the oroenteric catheter. We can define the afferent loop under fluoroscopy. We can place the tip of our echoendoscope at the desired location, and then we can proceed with creating the gastrojejunostomy. And you're already very well familiar with the steps for the LAMS placement. So in summary, we need CT for diagnosis, but we need enteroscopy to establish the etiology. And remember, the etiology in a patient with history of prior malignancy may be benign if prior radiation was received. Patient with history of cancer, then the etiology is most likely recurrence, and we're looking at palliative objectives. Enteroscopy guided treatment can be technically challenging. Increasingly, we're probably going to bypass that, and we're going to go to EUS-guided bypass. And this requires favorable anatomy, so we may need to assist that with placement of an oral enteric catheter. And finally, remember that EUS-guided hepaticogastrostomy is a very viable alternative to afferent loop bypass, provided the intrahepatic ducts are dilated. Thank you.